Hello, welcome to Holistically Speaking. I am Morella DeVoe, your host. Our mission with Holistically Speaking is to be the avenue through which the voices of holistic health reach you at the time you need it most. For the last 2 weeks, we spoke about depression and suicide, and this is the third week that we're talking about this really important subject, and I wanted to bring to you another perspective. And my guest today is Dr. Bree Greenberg-Benjamin, and I said, doctor, you're a psychotherapist, right?
I am.
I think I'm just like programmed to call you doctor, so.
I'll take it.
Welcome, Bree. Thank you for joining me.
Thanks for having me.
We were part of this conversation many weeks ago where we started talking about the possibility of having a show on depression and suicide because of the recent suicide of a law school professor in Vermont. And we were already talking about all of this when we heard about Robin Williams' suicide, and I think that shocked everyone. And it started to make the topic come up to the surface, to people's awareness. Why is suicide such a rising concern and depression seeming to be a growing trend? So one of the things where we started off the show with Heather last week was the statistics showing that depression is in fact increasing in the U.S. It's rising. The suicide rate in the state of Vermont is higher than the national average. So it seems to be a growing issue. Is this what you've observed in your practice?
It's an interesting question. I mean, I think in our practice, we always have some of that comes up. So it's hard to quantify whether it's more than it was. There seem to be certain periods of time where it's exacerbated and we see more attempts. And I can make some guesses about what that is, but I don't really know the reason why it comes in waves.
Right.
And it feels like it kind of comes in waves.
Okay.
I think I want to say too that like when we say depression, there's a wide category of what depression is.
Yeah.
You know, like sometimes people will come in and they'll say, I'm depressed, and I'll say, well, what does that mean to you? Like, what are you experiencing? And I think because of like commercialized medications, we see a lot of like TV spots for, are you depressed? Do you have these list of symptoms? And most Americans identify with at least some of that. Many people are overworked, undernourished, and I mean that in like the heart sense of being undernourished, and they're disconnected. And so that's already going to bring up a lot of the symptoms or conditions that seem to be attributed to the quantifiable definition of depression.
Interesting.
Yeah.
So do you think that part of the perhaps increase in depression is that we're telling people this is what it looks like to be depressed, and people saying, yeah, I think I have that?
I think that's some of it. I also would say that what we see an increase in is dissatisfaction. So I like to separate depression from dissatisfaction. There seems to be a lot of global sense of malaise or dissatisfaction with life, like what we call dysthymia, than there is as much kind of clinical depression.
Okay.
Clinical depression is a much more severe form of that.
So can you define for us what clinical depression would be?
I can't tell you what the DSM says it is because I don't remember the criteria, but I can say that clinical depression is a more pervasive form that is more paralyzing as far as being isolating and very, very low mood, and is not always accompanied by suicidal thoughts.
Right.
So there's this idea sometimes that you have to be clinically depressed to be suicidal. That's ridiculously untrue.
Oh, okay.
Lots of people are suicidal without being clinically depressed. Lots of people become suicidal because they're very anxious, not because they're necessarily with depressed mood.
Oh, interesting. So they may have never felt like they're depressed, but the suicidal thoughts are still there.
Exactly. And when you think about depression, you think about like a mood disorder, right?
Right.
And mood is more around like the tone of what's happening in the mind. And so it's interesting to think about where is the global tone for people. And that's where the dissatisfaction or the like aversion comes in for a lot of people. That's that chronic grumpiness of like, my life just doesn't feel right. Something's just not there, it's missing. And a lot of times we call that depression.
Okay, so what you're helping to clarify for me, and I'm sure for everybody else, is that there's the general dissatisfaction with life that many of us experience, you know, not liking your job, you know, not liking your landlord or whatever, you know, just having that sort of grumpiness.
Yes.
And then depression is something completely different.
Yes. Yeah, depression is much more long-term and much heavier, and is often accompanied by much more isolation or like disconnection from life in general.
And in the spirit of clarifying all of this, I've also heard that depression isn't necessarily sadness or just sadness.
Right.
So can you paint a little bit of a picture of what depression does look like or feel like?
It can look like irritability, it can look like social anxiety, it can look like insecurity and a lot of self-doubt. So all those things can get mixed into the equation, which is why I think that definition has become so expansive and has left so much room for people to fit it into how they define themselves and their character. And their state of mind.
And say, I fit this category.
Exactly.
Yeah.
Exactly. Yeah.
The other thing, too, that is, it's interesting because I grew up, as you know, I grew up in a different country. And I moved to the U.S. in 2001. And in Latin America, in Venezuela, there were no ads for medication. I never saw on TV any ads for medication. And then I moved to the U.S. and I saw all these ads and I thought it was ridiculous. So the reason why I thought it was ridiculous, it was because I knew that you need a prescription in order to get these medications. So I thought, why are they advertising this? People can't just walk into a pharmacy and order this. But what do you see, or have you seen these ads as having an effect on maybe on diagnoses or an effect even on the number of prescriptions that get handed out?
Absolutely.
So you do see that?
The ads, and also I think the access now to like WebMD or a way to self-diagnose online.
Right.
So there's lots of questionnaires that you can take to see what your diagnosis is.
Right.
And all of that leads people to make conclusions about what's happening.
Right.
And there's an upside to that too, which is that sometimes people are struggling with experiences inside that they can't quantify. Sometimes having a name for all of that is really unburdening and gives a lot of ease. It's like, oh, that's what's going on with me.
I'm not alone.
I'm not alone. Like there's something that's really true about that I can fit myself into. But it can also be dangerous because when you fit yourself into a certain category, you become limited immediately by that.
Right.
So it's both pieces together.
Okay. So what about suicide? Is this something that you have seen? I know you mentioned waves, you know, that it comes in waves in terms of depression. Is suicide something that you have seen on the rise? I personally, in the last couple of months, I have heard of so many suicides and, you know, suicide attempts. And it's just been kind of startling. So what has been your experience or observation at the Vermont Center for Integrative Therapy? What's your perspective on it?
We definitely have seen a rise in not only just attempts, but thoughts and ideation around suicide. I mean, my global thinking about it is that the world is pretty unstable right now, and things feel pretty vibrationally unstable to people. Everybody is in a time of a lot of shift, both in the micro and the macrocosm, and that tends to bring up a lot of fear and a lot of old patterns and old thought processes, and suicide is a wonderful way out.
Yeah.
It's a tempting way for the mind to say, I don't have to feel any of that anymore.
Right.
An interesting thing is that most people who fantasize about suicide don't actually want to die, they just don't want to suffer anymore.
Right.
And that's a huge difference in the way we conceptualize suicide generally, which is this idea of that person wants to die. So
Right.
if they have the offering of not to suffer as much, but to live, most people feel the
Right.
inclination towards that.
Right. That is an enormous point to help make people aware of, that the majority of these people don't actually want to die. They just are really unhappy
Yeah.
that they would love to end their suffering. They just don't know how. Perhaps.
Right, and in a lot of cases, people have tried a lot of different resources to end their suffering, and then a certain kind of hopelessness arises, and with that hopelessness, that's where the suicidal part can really come in.
Yeah.
It's kind of like, I'll bail you out.
Right.
You know, you don't have to feel this anymore. You don't have to keep trying and failing.
Right.
Yeah.
Right. So let's talk about how you at the Vermont Center for Integrative Therapy approach depression and suicide prevention. And maybe to set the context for our viewers, even though you've been on the show in the past, maybe we could just clarify or share with them a little bit of what your center is about.
So I would just sum it up to say that we're an integrative mental health center. We have many different disciplines who practice within the scope of the center: psychotherapists, psychiatry. We have an in-house diagnostically specific yoga program with yoga therapy, chiropractic, massage.
Wow, so I just have to pause for a moment. So you're mentioning diagnostically specific yoga therapy. So meaning that you have a different yoga class, say, for anxiety than you might have for depression.
Correct.
Wow,
Yeah,
that's
right.
fascinating.
Yeah, and we tweak the interventions based on what that diagnosis is. So from a yogic perspective, anxiety shows up with a certain kind of energy and affects particular chakras. So we're going to be looking at that when thinking about what kinds of interventions are selected and utilized within that program.
So since we're talking about depression, what would be the yogic perspective on depression?
Well, so depression is going to be a very heavy, energy. It's going to be a very low, weighty energy. So there's going to be the desire to unblend some of that, break up some of that energy, and provide some freedom from it, as well as get some more flow in the system when it's pretty stagnant. So there could be breath work that is along those lines. There might be a lot of standing postures or balancing postures just to bring your mind home to your body.
Right, and I would imagine, I don't know why this is popping to mind, but I would imagine opening postures, like a lot of kind of opening of the body as opposed to the contraction that probably is a part of depression.
Right, you want to go from this to this. But also being really careful around that and mindful of the fact that a lot of times the etiology of depression is old trauma. So also being really aware of the sensitivity of the heart and the chakra that is there and how that may have been affected in the past. So we're looking at all of that and keeping our groups for the yogic series very small so that there's room for the instructor to dialogue with the participants, really customize each of those participants' journey through the series.
Wow, there's so many things that you're saying that are prompting me to ask other questions that are more about depression than necessarily yet about the treatment. But you just said that, oh my gosh, the thoughts now escaping me. But you were just talking about depression and the trauma that often accompanies the depression, or is in the etiology of depression. So that makes me think that contraction that is typical of depression, that kind of shutting down, is perhaps a protective type of a...
That's right.
Interesting.
Exactly.
And so you can't just, force someone or try to shake someone out of, their depression, because this is their protection mechanism.
That's right, and that's why it will be largely resistant if that's what you're trying to do. So it's more about embracing what's present and how it's present and what purpose it's serving, rather than trying to make it go away. And that's a very different perspective from most of the medical world, which tries to erase it with medication or thinking a different way.
Yeah. So with the topic of medication, and this was actually a conversation very recently amongst a group of friends, where there's so much of this generally accepted perspective that depression has something to do with a chemical imbalance in the brain. So how true is that? Is it true entirely, or in some cases, what's your perspective on this?
I mean, I don't really know the answer to that. I can say that there's definitely a lot of truth to lineage inherited genetic depression and other mood conditions. When we interview people who have depression, especially clinical depression that has been there a long time, you often find history in the family.
Yeah.
So there's certainly something to that. Where I begin to get interested is around the differences between the lineage inheritage of the genetics or the biochemistry and also the energetics. So what's inherited too, just in our typing, the way our energetic composition is inside, and how that maybe leans us towards behaving and being a magnet for certain things in the world. That's really interesting to me. And I think we don't know so much about that yet.
Okay. So let's go back to looking at how you at the Vermont Center for Integrative Therapy typically approach someone who walks in and meets the criteria for depression.
So the first thing we're going to do is ask them what that means to them and how it's shown up in their life. And we're going to try and take them away from the diagnosis and into just the experience of it. And that could be having them experience it in their body rather than just talk about the experience of it. Or it could be doing both, having them have a narrative and talk about their narrative of experience, and also dive into that through language, as well as really try and feel the embodiment of when depression is present. What is that like in the body? Does it come over you? Does it inhabit you? What's your relationship to it? Can you breathe into it? Can you separate from it? What is it trying to do for you? All of those things.
And what does that help someone do as they have this conscious experience of what the physical sensation of depression is like?
Well, there's two things about the body. One is it can give you lots of information about the past and the present. And the other piece is that, and I'm sure you and Heather talked about this, is that you can intervene into the body's energetic system to really change the mood. And so there's a couple different ways that we might use the body. But the other piece that's there too is that much of the way mood disorders become problematic for us is not the experience of depression itself, but how we feel about having that experience. And that's something that's very malleable. So if you can make friends with that experience, then it doesn't have so much power over you, and it isn't the extra layer of the secondary suffering that comes on from hating it.
Yeah, the feelings you're having about the feelings.
Totally, totally.
Wow. And so you take someone, you have them experience their physical sensations of the depression to have that body awareness. How else do you work? What are the different, because I know you have different approaches to working with people, so how would you typically work with someone?
Well, so some of it matters too, what is the history of that? If there's trauma there in the past, we're going to be looking at that and working with that and determining what should come first. So most of the time, people who come in with a mood condition also have stuff that has happened in their history that hasn't been dealt with. They may want to come in and deal with the mood condition first, but that may not be the logical first place to begin. So we're looking and talking with the client about where do we innervate this system to begin with, and what kinds of interventions will work most effectively. If it feels very acute and very strong, then we want to do something that's going to help to lift some of that so the person can get some relief before they can do the work from the past. But if they're pretty used to feeling that way and it's not very acute, and they really want to make more long-lasting change without like medical intervention, then we may do something like send them to yoga and also send them to a psychotherapist and also maybe send them to a chiropractor. So we're looking at how to tweak the system all at once and also not overwhelm the system. Because there's only so much you can digest at one time. So we're pretty careful about that.
And then how do you integrate the nutrition and naturopathic aspect?
It's a great question. So some of that is that we're evaluating that. What is this person's diet like? Do they have food allergies that might connect to what their depression is? You know, we're looking at all of those pieces. So there might be testing that we do. There's long histories that our naturopath might take, as well as our dietitian. They may work together. We also now offer acupuncture. So all those things are a possibility. Much of what we do at the beginning is really evaluate the whole system of the person.
Okay. And my next kind of pressing question is there one approach or strategy that you have found across the board people with depression typically need?
No.
No.
Everybody feels so individual to me.
Okay. Now, in terms of, and I'm always curious for new and different perspectives on the nutrition piece or the naturopathic piece, because about a year ago, I mentioned this also last week on the show, I had a naturopath on the show say that he had yet to find anybody in the state of Vermont that was not vitamin D deficient. And we know that
I've heard that.
And so we know that vitamin D deficiency has a strong correlation in mood disorders. So is, for example, vitamin D supplementation something that you guys do or look at, or are there strategies like that that you know typically are helpful to people with depression?
Absolutely, but it's not something that we, again, prescribe across the board.
Okay.
It's more of a very individualized approach to where is this person. And some of that is looking at where are they inside, but also what is their outside experience like. So we might prescribe for them to get outside more before we prescribe them vitamin D.
Right.
So it just depends on how low their levels are.
Right.
We also look pretty exhaustively at hormones, especially in women, because so much of that correlates with mood as well.
Oh, wow.
And there's so much adrenal fatigue in our society these days.
So what's interesting in your approach, and just to kind of bring it all together for our viewers of all the different things you've mentioned, is that you look at the specific etiology, how people are experiencing the depression in their bodies. You look at their nutritional needs, their activity levels, all of these different factors their hormones, as you just mentioned, to see what is the possible best course of or the best approach.
Yeah, and where to begin. Because it may be that where we begin isn't where we are 3 months later. Right. So we may begin with one intervention and then 3 months later find that we need something different. So we can really adapt and shift with that client as things shift for them as they do the work.
Okay. So I want to switch gears a little bit and talk about suicide before we run out of time. So suicide seems like such a tricky subject. Like nobody really talks about it. Nobody really has the language. We don't know what to do about it.
Feels big and scary.
It feels big and scary.
It's part of the problem is that it feels big and scary.
So what can you tell us about suicide prevention, and what are some things that maybe our viewers should be made aware of?
I feel like the biggest suicide prevention is talking about it.
Yeah.
I think the biggest thing about suicide is that it is so under wraps, and people get so frightened when somebody starts to have suicidal thoughts.
Right.
Suicidal thoughts are not the same as actually having an attempt.
Okay.
Lots of people have fleeting fantasies of suicide and never attempt.
Right.
And I think it helps to understand that feeling suicidal is just a more extreme version of escape, which we're all really comfortable and familiar with because lots of people go home and drink their wine and watch television.
Right.
And suicide is really on that same continuum.
Right.
So if you understand it as having that function, I think it becomes less scary that way.
Yeah.
And that if you see somebody who seems very low and is feeling very hopeless, there's a good chance that there might be some suicidal thoughts inside, and it's a great opportunity to just say, hey, do you ever think about just ending your life?
Yeah.
And if they say yes, to say, that makes sense to me. Like you've been struggling with mental illness or like this feeling for a long, long time. Why wouldn't you feel like that?
And I would imagine, though, for most people, asking that question would feel really scary. A lot of people might say, "Well, I don't want to put the idea. I don't want it to sound like a suggestion."
Totally. Totally. I was saying yesterday in a group that I was training, and we were talking about suicidality, and I was saying it was kind of the same argument as we made about like not putting condoms in schools.
Right.
That we thought that if we put them there, everybody would have sex, but guess what? They're all having sex anyway.
Right.
And so it's kind of the same. People are fantasizing about suicide and attempting, whether we're talking to them about it or not. And if you bring it out in the open, the chance of somebody having an attempt is less.
Right. And then what's the recommended approach if you know someone who is suicidal and you're pretty certain that they're thinking about this somewhat seriously? Obviously, therapists have, I think therapists have an obligation to report it to someone or to do something about it. But, you know, the layperson isn't really under that obligation. So what do we do?
Well, it's good to know that there's a crisis hotline, and it's 24 hours, and lots of people use it, and it's good. So that's definitely a phone number that you can give to somebody and just say, if you're having these thoughts, this is an easy thing to do anytime, day or night.
Right.
It's also worthwhile getting evaluated at the hospital. Howard Center staffs the hospital and can do those evaluations at any time through the ER.
Right.
And also to say to somebody, let's get you in some longer term help.
Yeah.
Where you can really talk about this.
Yeah, and I love your center because it offers such a variety of approaches and services. So I want to be sure that people know how to find you. So we have a slide where you can see how to contact Bree and the practitioners at the Vermont Center for Integrative Therapy, and that website is vtcit.com. And some of the services they offer are body work, craniosacral therapy, yoga, naturopathic care, nutrition, meditation, eating disorder intensive programs, Reiki, acupuncture, it's psychiatry and psychotherapy, of course. So in conclusion, if you're thinking about the person who's watching this show and maybe feeling like this is something that I can relate to, what are some simple things that you would suggest that they consider?
So if somebody's not ready to go to therapy, if they're pre-contemplative around whether they're going to get help for some of those feelings and thoughts that are coming up, a great thing to do is just go get in your body. So get moving. Take a walk on a regular basis, go to a yoga class, take up some meditation. There's lots of that in town. Those are easy ways to begin dabbling in some of that. Get a body-based worker like a chiropractic person or a massage therapist. All of that will make energetic shifts, even if you're not ready to talk about it.
Yeah.
And certainly if you are ready to talk about it, reach out and get somebody to talk to.
Right.
Yeah.
And the other piece that's super important is for those who are watching and maybe are not necessarily feeling it, but they know someone close to them who might be in that place, that these feelings and these thoughts are already occurring. So having the conversation is definitely something that will likely be welcome, do you think?
Well, maybe not welcome, but powerful. So generally when you name something, it has less power. It has a lot of power when it's underground. And so just knowing that keeping things out in the open already makes them a little bit less captivating.
Yeah. Well, thank you so much for joining me and talking about this important subject.
Thanks for having me.
It is so refreshing to know that there's a center that has, it feels very welcoming because there's such an array of services that it feels like you're not going to be fit into a box, as if you've been saying.
Yes.
That, you're just going to show up and they're going to help you, or you are going to help people figure out what they uniquely need and what's right for them at that time.
Yeah, we just try to meet them where they are.
Excellent. Well, thank you so much for joining us. I am sure you learned as much as I did about depression and suicide, and I hope hope you'll join us next week. We're going to be sitting with Bree again, and we're going to be talking about eating disorders, another very important topic. So join us next week, and we hope to hear from you. Be well.